All right. All right there. Hi, everybody. My name is Dr. Ben Pupo. I am the founder of Inland Northwest Neurological Performance here in Coeur d'Alene, Idaho. I'm a functional neurologist, so I'm a chiropractor, but I am a diplomate of the American Chiropractic Neurology Board, as well as a certified brain injury specialist through the Brain Injury Alliance of America. So, what I am trying to do is start a little lecture series, talking about a few different aspects of patients that I see, conditions that I treat, to give folks a little bit better of an idea of what it is they can expect when they come to see me. So prospective patients, if they're wanting to learn a bit more about, say, a certain topic, or maybe a current provider or doctor who's wanting to learn a little bit more about what it is that we do, or how they can start to implement some things that we utilize in our clinic, in their own. So the first topic that I really wanted to start working with and presenting is concussion and its effects on depression and how it can result in mood related disorders. And so that's what our topic today is going to be about. If there's a topic that you want to see me speak on in the future, or we'll learn a little bit more about, why don't you comment in, and we can start a dialogue and see if we get some different topics going. I have a couple ideas of where I want to go, but of course I want to listen to people who are watching, and see if there's something that interests you guys. So yeah, let's get going. So we're going to talk about concussion and depression, why it is that, hey, why am I feeling this way, and what I can start to do to begin the healing process. So let's jump in. What's super important for us to go over is, what is a concussion, right? Really, really frequently I get people in my clinic where they've been diagnosed with a concussion or a head injury, they've been into a car accident, and they legitimately have no idea what's going on within their body. Maybe they feel really gross, maybe they have certain symptoms. They go to the emergency room, they go to the urgent care, they're told that they have a concussion, um, but then they're kind of left in the dark. Oftentimes, if you're seeing somebody who knows what they're doing, they'll say, yeah, you know what, you should feel better in a week or so. It's important not just to, say, sit in a dark room. Um, it's important to become active after you have that injury, after, say, 24 to 48 hours. That's really important. But understanding what a concussion is, or the explanation of what a concussion is, just typically doesn't happen in my experience. So let's go over a little bit what that is. So from a definition standpoint, a concussion is a transient metabolic change that occurs within the central nervous system that can alter its function, either temporarily or, in really severe cases, permanently. Most often in my clinic, I'm going to see mild traumatic brain injury and concussion, and usually we're always going to be able to make some sort of positive change with that patient. How much change? That remains to be seen. That, unfortunately, there's no way to guarantee anything, but usually there are things that we can work on, whether it's through quality of life, ability to move throughout the world, or symptom resolution. So a concussion can be caused either by a direct blow to the head, the face, the neck, or somewhere else in the body that's going to create an impulsive force that's transmitted either through the neck or the head. So a really common misconception about head injuries, or concussions in particular, is that you do not need to actually hit your head in order to sustain one. Really commonly, I'll see folks who are in, say, car accidents, or they sustain falls where they actually never hit their head, but they whiplash their neck, or there's some really intense force that's moved through their body that allows their head to kind of move around, right? More so than what we would want, and at a higher force than what we would want. So when that happens, there are specific areas within the brain that are more commonly injured than other ones. So that being said, I mean, the short term things that we're looking at here are impairment of neurological function, right? Meaning that could be, cognitive symptoms. It can be dizziness. It can be lightheadedness. It can be emotional issues, right? and typically they're going to resolve spontaneously on their own. Um, so the resolution of these things is going to usually follow a sequential course. So just over time, you're just going to get kind of better and better over time. But and there are some cases where symptoms are prolonged, and those are the folks that are here working with me. Or if there's a functional neurology clinic near you, those are the folks that are in those clinics. Another really common misconception that I have on here is that the concussion may or may not involve a loss of consciousness. So this is, yeah, a really common, kind of myth, like, oh, I didn't lose consciousness, so I don't have a concussion. That's just not true. In fact, only 10% of head injuries or concussions involve a loss of consciousness. So it's a really big percentage that involves, nobody losing consciousness. So important to note. So once someone sustains a concussion, and let's say their symptoms are a little bit more prolonged, like we were just kind of talking about, we delve into the region of what's called post-concussion syndrome. And we can think about this in two parts. So there's an early phase stress disorder that we commonly see as headache, dizziness, imbalance, fatigue, sleep disruption, impaired cognition, like I mentioned earlier, and light and sound sensitivities. The second part is more of a late phase stress disorder that consists more of body, emotional, and cognitive symptoms that persist. And these symptoms are highly influenced by various psychological factors. And it's actually less specific to the injury itself, but more so the brain that was injured. So what are you predisposed to before that injury? Right. And so this is going to be a huge topic that we're going to talk about in the next few minutes. So symptoms that I frequently see, fatigue, anxiety, dizziness, headache, cognitive and a memory difficulty, and a lack of emotional regulation. So that goes on, we need to talk about depression, right? Or a lack of emotional regulation. What is it? So the DSM-5 outlines the following criteria for clinical diagnosis of a depressive disorder. So I'm not going to go over all these since it's kind of a long list, but I am going to mention the highlights here, the bolded topics. So the first one being a depressed mood most of the day, nearly every day, right? A markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. This is something I see super commonly. Someone who's a very, say, high executive functioning person, a professional in their career, they sustain a head injury, maybe they're involved in a car accident, and then all of a sudden they've lost all motivation for their work, maybe for a hobby. I had a guy in here not too long ago who loved to fly fish, sustained a head injury, and then has no interest in fly fishing afterward. So that is a very, very common thing. Additionally, a slowing down of thought, a reduction of physical movement that may or may not be observable by others, but it's not merely just a subjective feeling of being slowed down or lethargic. Fatigue is a huge one, or a loss of energy that folks feel, nearly every day. And then lastly, I'll mention a diminished ability to think or concentrate, or indecisiveness. Another good term for this is brain fog. So depression is a very, very common thing. So 1 out of 5 people are going to be diagnosed with some sort of major depressive disorder sometime in their lifetime. And now it's one of the leading causes of disability in the US. Females are going to be affected more than males, almost 3 times as much at a ratio of 5 to 2. And it's estimated that only 50% of depressed patients are currently responsive to available antidepressant treatments, which is a big deal, right? So antidepressant medications are usually one of the first lines of treatment for depression, amongst a few other things, but only 50% of the time, this study here has said those antidepressants are going to work. And for those who don't respond to those therapies, it's easy for those folks to feel like there's no hope or there's nowhere else to go, but there are other routes available. And so the pathophysiology surrounding depression remains, pretty poorly understood. But it's likely a combination of the things I have listed here, which are genetics, what'd you get from mom and dad, their environment, what sort of context are you living in, previous life experiences. So things like trauma, emotional, physical abuse, that kind of thing will fit into that. Biochemistry, which is a neurochemical type, say, imbalance, right? So this kind of leads me to a point that I'd like to make is there's been some really interesting studies done in the past several years where they've really delved into the pathophysiology of what's happening in folks who have depression. For a long time, we thought that there was maybe some neurochemical imbalance, there was neurotransmitter imbalance. But in reality, what we're learning is that depression may actually be more of a connectivity issue. And that's that next bullet point. How do areas of brain communicate with other associated areas? And so we'll talk a little bit about some anatomy here in just a second, but all 5 of these bullet points make a cocktail or a cauldron, so to speak, of factors that can affect somebody's brain. So let's connect the two things, concussion and depression, because there's quite a bit of overlap. Post-traumatic brain injury depression is going to manifest about 25 to 50% of the time in patients within the first year following injury, and then a quarter to just about 3/4 over their lifetime. So in one study, researchers found that 42% of 722 adults with traumatic brain injury had a depression diagnosis following injury. So nearly 50% in this one study. And another one, a third of patients with traumatic brain injury were diagnosed with depression by psychiatrists following traumatic brain injury. That's a stark contrast to the 8% of control patients diagnosed with depression without history of traumatic brain injury. So there's definitely a connection, right? So we need to talk a little bit about risk factors for developing, say, depression or some of these late stage post-concussion disorder type things. So we're not going to read through all of these, but I want to highlight factors here that are going to make your symptoms worse, your depression worse, your cognitive challenges worse. The first one being intense, major early signs and symptoms of headache and fatigue. Those are correlated really highly with prolonged recovery. A history of multiple concussions is a huge one. History of already present psychiatric disorder like anxiety or depression. So this goes along with our point that we were kind of making earlier, that how you basically will recover has a lot to do with what your brain is like before you sustain that concussion. So if you're more predisposed to, say, something like depression, bipolar, whatever it is, you're more likely to have that happen as a result of a head injury later. A higher initial concussion symptom score, so more severe symptoms, are going to be more of a risk factor for development of these late stage post-concussion symptom disorders. And a higher emotional early post-concussion symptom subscore, those things are similar. And a presence of pre-injury psychiatric history. Couple more stats here, and then we'll kind of bring it all together. Concussed athletes with symptoms of depression at baseline. This is a really interesting study. 4.5 times more likely to experience depression symptoms after they have a head injury. Second bullet point there's a 3-fold lifetime risk of depression in retired professional football players who have 3 or more prior concussions. So there's certainly a connection between head injuries and mood regulation disorders. So I mentioned we were going to talk a little anatomy. We're not going to go too deep into this because it is rather complex, but I do want to highlight some areas here that are really, really important and that we as functional neurologists are going to look at in examination and rehabilitate if they're dysfunctional. So there are a bunch of areas within the area that have been implicated with pathophysiology of both depression and brain injury. And they've done that through MRIs, functional MRIs, and SPECT scans, and a few other tests. And I have them listed below. The dorsolateral prefrontal cortex, or the DLPFC, which is kind of like right. I don't know if you can see my mouse moving, but it's if you were to drill a hole, kind of like right through my head, right there. It's a very, very important area for functional neurologists because not only is this area, um, you know, involved with mood regulation, attention regulation, working memory, personality, that kind of thing. But it's also playing a major role with eye movements, specifically what are called saccades, which is a fast eye movement from one point to the other. So if I were to look at one thumb and then quickly move my eyes over to the other thumb, the dorsolateral prefrontal cortex is actually going to help me drive my eyes in the direction that I want to move them. So, which is really cool for us because we have ways where we can actually measure the speed, the accuracy, and our reaction time with these eye movements. And that can give us an idea, okay, your dorsolateral prefrontal cortex over on the left, or say over on the right, isn't working as hard as it should be. And oftentimes when we see an increased reaction time, or what we call a latency, where it takes longer for somebody's eyes to move to a stimulus, we can basically, deduce that, hey, you know what? That area, not only is that brain area not working as well, but you're likely going to have some sort of, mood issue or attention issue if you don't already have it. So there's a couple more here: the medial prefrontal cortex, the anterior cingulate cortex, and orbital frontal cortices, and the insula are all highly implicated with concussion and depression. So a couple more notes on those. The prefrontal cortices with their complex neuroanatomic pathways and connections to other cortical and subcortical, meaning a little bit deeper within the brain, they serve to establish long-term memory and executive functions, and their injury during traumatic brain injury leads to serious behavioral abnormalities. Increased distractibility, forgetfulness, difficulty focusing one's attention and concentration on a mental task, impairment of working memory, or like short-term memory and retrieval, dysexecutive syndromes, and disinhibited behavior can all happen as a result to injury to these areas. So a lot of these we've mentioned, these executive function impairments. So what exactly are those? I have those kind of listed down here: initiating and inhibiting responses, right? Planning and completing goals, understanding something that you need to do today in order to basically fulfill a long-term goal a year from now. That's really difficult with an impairment in these areas. Mental flexibility. I see patients all of the time who feel not only mentally inflexible, but emotionally inflexible, where they almost feel caged in with their decision making. If, say, something at work doesn't go their way, there is no other option in the world, and they feel like, you know what, I can't do this job anymore. I have to quit. Instead of processing, what is happening and say, is there a solution to this problem that I'm currently presented with? If people almost feel pigeonholed, so to speak. And that goes along with the next bullet point. Problem solving and conceptual reasoning becomes really difficult. Complex thinking is really challenging. Decision making becomes difficult. Working memory, which is like what happened in the last, say, 5 to 30 minutes. Memory and attention processing, like we've mentioned. Emotional response regulation and self-monitoring. How I shouldn't tell someone a certain thing given a certain context. Like when your wife asks you, hey, how do I look in this dress? It's how you understand to know. You say, you know what? You look great, honey. Right? So that goes along with the next one too, which is appropriate functioning in social situations, right? How I know not to tell, my neighbor to, screw it, right? Pardon my language, but how I understand, manners and social context and structure. So let's talk a little bit about recovery timeline. Most adults that deal with concussion or traumatic brain injury are going to recover within 2 weeks. Some studies are going to say 50% of folks. Some studies are going to say around 75% of folks are going to get better within those couple weeks. Children are going to take a little bit longer. They're going to typically recover within 28 days to a month, maybe a little bit longer. They just take a little bit longer. Males are more likely to be symptom-free at 1 month. The quote unquote usual recovery timeline for a person with post-concussion syndrome can evolve over weeks to months, and most folks are going to fully recover from early phase symptoms within 3 months. However, there remain a population of individuals who don't recover fully and may experience post-concussive symptoms for up to 1 year or even longer. I see this all the time in my clinic here. I've seen folks who've been dealing with post-concussion syndrome for decades. So the longer that these things perseverate, the more chronic they become, the more challenging they become to recover from. That doesn't mean that you can't recover, but it just means that it takes more strategic rehabilitation and a lot more aggressive, say, diet planning, lifestyle modification, etc. So now we've talked a lot about negative stuff. So let's talk a little bit more now about, the positive stuff. What steps can you take now to start feeling better, right? Start recovering from your injury. There's multiple things, multiple things. So the options range from pharmaceuticals, which, for a lot of folks is that kind of first option, the first thing that they're exposed to when they're recovering. If it's pain medication, anti-seizure medication, antidepressants, like we've mentioned before, anti-dizziness drugs. Those are usually the first thing that, that people are going to go for with persisting symptoms. But there's many more. There's cognitive behavioral therapies, physical therapy, chiropractic, psychiatry, vestibular rehabilitation, which I do a lot of, as well as functional neurology. And we'll get into that in just a moment. Transcranial magnetic stimulation, which is really cool. There's been some really awesome research coming out about this, and some really awesome providers who are putting this into practice a lot more recently. Essentially, they're going to put a big MRI strength magnet pointed right at the dorsolateral prefrontal cortex, which we were talking about earlier, and just bombard it with magnetic stimulus. And for post-traumatic stress disorder and depression, it's been working pretty well. I don't have the exact numbers and how effective it is, but it's certainly something to look into if you've been dealing with symptoms for a long time. Hyperbaric oxygen therapy is another really cool one I have personal experience with. The pressurized oxygen will actually just drive a whole bunch of O2 onto your red blood cells, and more oxygen in your red blood cells essentially means more oxygen within your brain. And really commonly what I see as a result of head injury is a decrease cerebral perfusion of oxygen within the brain, with positional changes. Maybe it's all the time, maybe anytime somebody's upright, they just don't get enough oxygen to the brain. And that has its whole subset of symptoms related to it. And so hyperbaric oxygen therapy can be helpful for things like that. Neuro and biofeedback are good options as well as mental health counseling. So something that I work with, and that my approach basically consists of, is functional neurology. Functional neurologists will attempt to identify areas of your nervous system that aren't working optimally, and whose dysfunction might be the root cause of what it is that you're experiencing. And commonly, these systems that I'm speaking about are sensory and motor areas of the neuraxis, meaning just your brain, your nervous system, that are utilized to allow us to understand and how to interact with our environment. So these are your frontal cortices, which we've mentioned, somatosensory centers, your vestibular system, and your oculomotor areas, meaning your vision and how your eyes move in accordance to your environment. And this leads me to one of my favorite things to talk about when it comes to concussion in the brain, which is called the McLean paradigm. So I have a little model here of the brain. Hopefully everybody can see that. Okay. So with the McLean paradigm, essentially what we're talking about and breaking down is the nervous system into three foundational parts. The first foundational part is this. This is your brainstem and your cerebellum. So everything that we think to be automatic with our body basically occurs here. So our wakefulness, our heart rate, our blood pressure, our coordination while we're walking, our eye movements, a lot of control of our gastrointestinal tract will occur in these areas here. Essentially, this foundational system keeps you alive. It keeps you upright and keeps your heart beating, right? The next level up would be kind of this area, right in here. My hippocampus, amygdala, my insular cortex. These areas are my cingulate cortex. These areas are really, really important for attaching emotional and memory response to previous experience. So it's just kind of that next level up in complexity. The third level would be this. This is called your neocortex. All these folds of fat and protein. And here is where you live, quote unquote. All of your executive decision making or executive function, like we've mentioned in previous slides, your decision making skills, your ability to critically think, your ability to monitor yourself in a social context, it all happens right up in here. So with head injury, really commonly what we're going to see is injury to this area down here, that primary system. You think about what happens to your brain during, say, a whiplash like injury. Imagine me kind of holding that stock, my brainstem, just like that, and then just kind of like whipping my brain around, just like that. So there's lots of rotary and tensile force that occurs through this area, and there's lots of really fragile axons and nerve endings that travel through this area that can become damaged. And when that happens, those automatic things that we were talking about earlier, they become less automatic. It essentially will force, and I'm oversimplifying things here, but I think that it's important for our conversation that we do. It will force these higher order brain centers to almost come down and modulate these automatic things. That leaves less brain power for what this should be doing. All of that executive decision making, that critical thinking, the regulation of your mood, right, becomes a lot more challenging because there's less energy devoted to it. Does that make sense? Hopefully it does. So what we do as functional neurologists is identify these certain symptoms or systems, excuse me, that are malfunctioning, and we work to rehab them if they can be rehabbed. If they can't, they're just too damaged. What we'll try to do is find an avenue or like a system that does work really well, and we'll try to compensate for the ones that don't work so well. Cool. So what does that process look like? So in my clinic, what we do first is we sit down with you and we take about 30 to 40 minutes and we do a medical history. We try to get a really good idea of who you are, what you got going on, what your past was like, things that you're predisposed to, if it is depression, right? If it is some sort of psychiatric disorder. Were you a dizzy person before you had a head injury, right? Did you already have issues reading? That kind of thing. Then we'll get into a bedside neurological and physical musculoskeletal exam, which usually takes around an hour. We're looking at your reflexes. We're looking at your eye movements. We're looking at your gait. We're looking at your balance, your muscle strength. Everything that your brain controls within your body, we want to take a look at, right? Because all of those systems can be affected. We do what are called VOMS tests or vestibulo-oculomotor screen. So essentially what we're looking for is can someone's eyes stay on a target is when that target is stationary versus when it's moving? Can that person's eyes stay on target as I move my head back and forth? Can I track, say, like a object moving quickly versus moving slowly? We need to look at all of these things. These are commonly dysfunctional systems after a head injury. Next, we do what's called a VNG or video nystagmography, which is a much closer look at someone's eye movements. And so we were able to film those and give objective readings as to, okay, here's what normal should be for your age group, sex, injury status, and we see how you compare to those. And where the research is now in 2025 is we can get pretty specific with whether or not you've injured one part of your brain or over another one based on the pattern that your eyes do or don't display. Along with the VNG, we're going to run what's called a sacidometer. And the sacidometer will look at the components of fast eye movements. So I mentioned this a bit prior, where we'll have two dots on a screen, and you'll be essentially, I guess, told to look at one dot over the other. And so we measure the speed, the reaction time, and the accuracy of those eye movements. And we can get really specific to parts of the brain or the neuraxis that are damaged based on if there's dysfunction in one of those things or all of them. We want to look too at reaction time just with like hand-eye coordination. That's a really good marker of frontal lobe function as well. And we're going to look at your balance. Balance is a huge component of this. I feel like we should do a whole nother video series just on vestibular and balance testing that we do as functional neurologists, and we probably will. So some rehab principles that we utilize, the first one being sensory motor reintegration. Our brain is particular about the sensory information that it likes. From a basic foundational standpoint, our brain needs to utilize three systems. It needs to utilize our vision, it needs to utilize information coming from our inner ear organs, and it needs information that comes from our body, specifically our neck, our ankles, and the rest of our spine. That information feeds back, and it feeds up, I should say, and it's going to meet up with information from my eyes and information from my inner ear to give me a really good idea of where I am in the world around me. How I know I'm sitting here in front of the computer, no one else is around, I'm talking to myself like a crazy person, right? Or am I like in a really busy grocery store, walking down the aisles? There's lots of bright lights, there's lots of loud sounds, babies crying behind me, there's lots of visual stimulus, right? These systems basically have to say the same thing. And really commonly after a head injury, those systems that should be doing this are kind of doing something like that, where all the time I tell my patients, hey, it's like your eyes are speaking English, your inner ear is speaking Spanish, and then your neck is telling you you're all the way out in the parking lot, so to speak. So what I mean with sensory motor reintegration is getting your eyes, your inner ear, and the rest of your body all on the same page again. And a big part of how we do that is that second bullet point, oculomotor training, training your eyes to move correctly and training your eyes to move correctly in regards to the rest of your body, right? Vestibular compensation and habituation. This is essentially just vestibular rehab. With compensation, we find systems that work well to compensate for the ones that don't work well. And habituation is a bit sadistic in its I guess in its basics. We expose you to things that make you feel gross, but in ways that aren't going to completely crash you out. So if turning your head to the left makes you feel dizzy, well, we should probably practice turning your head left first at a very slow speed, maybe with your eyes on a stationary target, and then we progress to moving you a little bit faster. Maybe we have you standing, moving while we turn your head to the left. This is all just hypothetical, by the way, but the whole aspect here is to start you at something that you can tolerate. Maybe it makes you feel a little gross, that's okay. But then we just make it more complex and more challenging as the rehab process progresses. Cognition and memory exercises are another huge piece to rehab, right? Brain games, can you remember the last, sentence I told you? How about three words? Blue fish house, tell them back to me in 5 minutes, that kind of thing. And then movement-based therapy. This is probably the most underrated of all of these. Moving our body is medicine. So one thing that I have not mentioned, and I think we'll talk about here in these next couple slides, is how medicinal movement is and how medicinal exercise can be. Exercise moves blood around. And when we exercise, we get more blood to our frontal lobes and to the rest of our brain. So a lot of times after a head injury, I'll see folks who have a mood disruptance, and I'll ask them, well, do you exercise? And they say, oh yeah, I try to exercise. And I ask them, okay, well, how do you feel when you exercise? And you know what? I feel awesome when I exercise. And then I stop, and you know what? My symptoms start to kind of come back. This is exactly my point. When we're exercising, we're pumping blood all over our body, specifically our head. We're getting good oxygen, we're getting good nutrients, and people feel better. when that happens. So exercise is a very, very important piece to this puzzle. So things that you can do now. The first one being setting realistic goals for yourself. Goal setting is a powerful exercise and can kind of get us started, right? And what I mean by goal setting is almost embarrassingly small goals, things that you know that you can accomplish, so you can teach yourself how to win. So like if going out to the mailbox is challenging for you, making that a daily goal can be really important. Maybe it's you're walking with your significant other or someone that can help you walk to that mailbox to get your mail. We can start there. The next day, we're going to do it again. The next day again. And maybe a week from now, I'm going to do it without assistance, right? So setting these little goals can be really, really powerful and working to reach those. That's what I mean. Using a planner or a calendar can be tremendously helpful. Leaving yourself reminders. We've already touched on exercising, and diet too. I think I'll do another one of these videos on diet, and how much of a difference, feeding your brain can make. Anti-inflammatory like diets, if there's something that we need to exclude. I'm not huge on exclusion diets. I'm usually going to recommend something like a Mediterranean diet to most folks, but depending on how aggressive, we need to get, we can. But diet is super important. So to wrap it all up, I appreciate y'all if you're still watching. There are reasons, why you're feeling the way that you're feeling, and you're not alone. And just because your injury is invisible, it does not mean that it isn't real. You don't have to feel like this forever, and there are options for treatment available to you. That's the big take-home thing, is that you are not alone. You don't have to live like this forever, and there are options available to you. So thanks, guys, for sticking with me here. Once again, my name is Dr. Ben Pupo. I'm the founder here at Inland Northwest Neurological Performance in Coeur d'Alene. You can find my phone number there. You can follow me on Instagram if you want. We can chat, shoot me an email. Like I said earlier, if there's something that you want to hear me talk about, we can do another one of these videos. Or if you're interested in becoming a patient, give that number a call and we can chat about your case. I do free phone consultations with all my patients. So give me a call. Thanks, guys.